It's my absolute pleasure to be here and particularly present after Ros, because Ros and I do a fair bit of work together presenting, and Ros is also very passionate about the area of sexual health and HIV. And like Sheila said today, it's never a dull area. It's never a dull moment. I get lots of questions about the area I work in. You can ask me anything about genitals, but I can tell you the answer, but don't ask me about diabetes or anything over 45. It's definitely not my area. It's also a pleasure to be here, particularly who saw Sheila speak this morning? Yeah. And Sheila's words were pretty powerful, and for a few reasons, because Australia, I'm going to present you some stuff today because Australia is a drop in the ocean with what's going on with HIV, and I got the honour to go to the International AIDS Conference also in Melbourne last year, and one thing that resonated with me at that conference was we have all the resources at our fingertips, and you know, we need to do more, and when I present some numbers and different things, I hope you guys will walk away today realising what impact and potential impact you do have in primary care. The other disclaimer I'll put on this is I don't work in primary care. You guys are the experts, but I think I'll demonstrate what impact you're going to have moving forward in this area. So I'm going to cover ending HIV. Has anyone seen the campaign Ending HIV? There's a lot of stuff going on in Australia, and each of the states are taking their own responsibilities with that campaign. Just a quick overview in Australia of HIV. I'm very much for interaction with the audience. How many people do we think are living in Australia with HIV? Have a stab. Because I had a really good conversation with a nurse yesterday, and she goes, I'm just talking randomly, and she said, yeah, I don't think we have many people in Australia with HIV. How many people do we think we have? Higher? Lower? Nearly there, 27,000, approximately, approaching 27,000. Where do we think those people are situated, majority of those? State-wise? Break it down state-wise? New South Wales? New South Wales and Victoria. But, you know, that picture's changing as well. So that just gives you a really quick overview of what's happening in Australia. Who is diagnosing HIV? And that's probably going to be the most important slide I touch on today for you guys. Some changes in HIV testing and counselling, again, a really important thing to discuss for a few reasons, because it's one of the huge barriers that I find in my work that clinicians say why they're not doing it. The role of primary healthcare, and in particular nurses, you guys are it. And some resources for education, because there's some great stuff out there. So just quickly, everything we work towards in HIV and sexual health, we have national strategies and statewide strategies. So this is the 7th National HIV Strategy. There's some ambitious targets, and I think the title of the campaign, Ending HIV, demonstrates how ambitious they're wanting to be. But as Sheila said this morning, there's the 0 by 2020 and there's the 90-90-90. We're getting on board with the world in terms of what we should be achieving, and to be honest, Australia should be achieving it. We've got all the resources, and that's what makes me, I guess, even more passionate about it. We've got it at our fingertips. But like I said, our numbers, so our statistics are speaking a little bit differently. Currently we've got 26,800, so nearly 27,000 with HIV, and our notifications just continue to go up. So yeah. This is just an example of the campaign, and you can click on this and you can see what you're doing in your state in regards to meet those targets. So in Australia, and I mean this is a really interesting slide compared to what Sheila presented, we've virtually eliminated vertical transmission. Now Sheila talked this morning how they've gone from 25% down to 4% of vertical transmission. High five Australia, look what we've done already. But in saying that though, we've got a protective factor where we do have low rates in that population, so it may not be really reflective of how awesome we are and that we screen every antenatal woman. It might be just the fact that we've got really low numbers, so people who do slip through the cracks, we're not going to know about it. So 70% of patients are in follow-up and on treatment, and that's going up and up and up because there's a real move towards treatment is prevention. So Sheila talked about that this morning. It has a public health benefit. More people on treatment, the lower their viral load is, the less infectious they are to others. So not only a benefit to themselves, but a benefit to the community. There's a wide availability of needle and syringe program. This is one area where Australia has really achieved above other countries. We implemented the needle and syringe program very early on, and because of that reason, we have extremely low rates in that population. A lot of people assume that it's high rates, but it's about 0.1% in that population, and we're maintaining that. So that's a really, that's a credit to us. So increasing treatment uptake among patients, and we're not in a country where access is an issue, so it's all about it's clinicians that have got to drive this. We do have access to treatment here, so it's our role, and falling mortality due to treatments. And that's where I think it's really important that we are on the agenda at the APNA conference, and we're in the lifespan section because these people are living longer. We're going to see them throughout their lifespan, and there's very much a shared care model happening. So you're going to be seeing them in your practices. They can't go to their specialist for everything. They do have other general health problems as well, which they'll be seeing you guys as well. So this just shows you that what's happening in Australia. It was 2011 and 2012, we had a 24% increase, which sparked a lot of concern, and particularly that's how my role came about in New South Wales, was to look at why that's happening. And Sheila mentioned it this morning, a lot of complacency, and that could be it. There could be lots of other reasons as well. But it's a concern because, like I said, we've got these resources at our fingertip and we're seeing that, which to me is devastating that we're seeing that. This just gives you a bit of a breakdown of who affects HIV in Australia. Now, we're different to Sheila's context in the terms that it's men who have sex with men that we see it predominantly here in our country. But that picture is changing a bit as well because Australia has a lot of people coming into our country that are from high prevalence countries. So it is changing. We are close to some next door neighbours where HIV is very prevalent. So it's much easier to travel. And this is where we run into issues where people just assume they don't fall in that category where they wouldn't be at risk. So try not to fall in that trap of, just thinking priority populations. But at this point in time, men who have sex with men is our main population affected. This is just to point out the breakdown within Aboriginal and Torres Strait Islanders, but what you need to take away from this slide is that their rates actually are quite low at this point in time. However, they've got a right mixing pot for that to just go the other way. So as health clinicians, we really need to take that on board and ensure we're putting the right measures in place in these populations. So although it's low comparatively to non-Indigenous Australians, the right conditions are there. This is probably one of the slides that I find most depressing. Is it highlights the estimated time between when someone's infected and when they're diagnosed, and that averages about 3.4 years. So you've got to think from a public health perspective, that person is circulating in our population infected with HIV for 3.5 years before they know. And call me sceptical, but you can't tell me in that 3.5 years they haven't presented at a healthcare facility at some point in time. So it's our responsibility wherever we can, and particularly in general practice, you've got more opportunities than anyone else. I still do clinic work in a sexual health clinic, and that's privileged because they go in there, they know I'm going to be talking about that stuff to them, and that's probably it's obviously their presenting problem, but you've got lots more, I guess, colourful opportunities where you can bring this up. So this slide I find quite depressing for various reasons. This is just an interesting slide to show you the continuum of care with someone with HIV. So you've got someone who's living with HIV wandering around in the community and they don't know their status. They're then diagnosed, and then hopefully by being diagnosed they're linked into care, and then hopefully once they're linked into care we can retain them, and we all know that how hard it is to retain someone in care with a chronic condition. This condition's no different. And once we get them in care, most likely they'll be put on treatment and then they're virally suppressed. So for them, it's now controlled. From a public health point of view, you've got a less infectious person in the population. Obviously, when someone's entered in care, they might enter in care but they're lost to follow-up. They might be intermittent in and out of care, or they might stay fully engaged in care. We've all got those patients that happens. This slide, again, kind of just reflects that in a graph point of view, but it just shows you over the numbers. So if they're living and then they're diagnosed, they're linked to care, they're retaining care, they're receiving treatment, and then they're suppressed. But the importance is to get through this cascade of care, what's the first thing we need to do? Identify them, test them. Yeah, we can't have any of this other cascade unless we're testing. So you might as well just rule out all the other columns there, because we need to test them first to get to this point. So let's think outside Australia. And for you guys, this is probably if you're working in refugee health, if you're seeing people that are travelling, it's always handy to know what's happening outside Australia. Now, some of my slides, me and Sheila obviously didn't communicate prior, are repetitive of Sheila's, so we're going to drill some messages home. This just shows you there's 35 million in the world living with HIV, and Australia, as I mentioned, is a drop in the ocean of that. We're very lucky here. However, I'm going to go on and talk about some of our next door neighbours. So when I'm talking about next door neighbours, who might we be thinking about? Papua New Guinea. Where's a really common place we go to for travel? Bali, Indonesia. Yep. So Thailand. And, you know, working in a sexual health clinic, I'll tell you now, things get cray-cray in Thailand. Things just happen that you just don't anticipate. And same with Indonesia. I keep up with the young kids, you know. They're the buzzwords. It's interesting when you ask the questions, and I think Mary put it really eloquently yesterday. She said, ask and you shall receive. So I normalise anything when I'm in clinic. Like, it might not be my normal, but I'm asking about ladyboys, you know. And it's surprising asking the questions when you ask it and it's rolling off your tongue like it's everyday activity, like I had my Cocoa Pops for breakfast. They're actually more than happy to tell you about it. So we've thought about some of our next door neighbours. So this table is not very clear, but I've just highlighted over the side here. You need to think Cambodia, Indonesia, Malaysia, PNG. I can never say Myanmar. Oh, I said it. There you go. Thailand, Vietnam. These are all really close to us. And if you think about young people, where they're going, I went to schoolies and I came to the Gold Coast. However, I met a young person in clinic the other day, and they went to Bali for schoolies. Like, oh my God. So, and you know, when you start talking, a lot of our travellers who come to Australia come via these countries on their way in, and they have no idea of the risks over there. So think about, you know, when someone is just having, we're nurses, we have general chit-chat. It's amazing what you find out through general chit-chat. If they're mentioning any of these countries, you need to think, what did they get up to while they were there? The other thing, so not only we think people going to these high prevalence countries, but people from these high prevalence countries. Don't assume because someone's on a visa they've had a HIV test. It depends on their visa. There's a lot of misconceptions around that, and I'm learning that as well. I assumed anyone that would be coming in via a visa would have a HIV test. Students that come in on student visas, no HIV testing. So don't assume just because they're on a visa they've had a test. Partners, that's another really important thing, particularly women. You're providing shared care. General practice or primary care plays a huge role in antenatal shared care now, and that's something we need to think about as well. People travelling to and returning from, and refugee health is another big one as well. So this is probably the most important slide that I'm going to present to you guys today, and hopefully you'll sit here and go high five us, or sit next to the person, high five. Who is diagnosing HIV? Who do you think is diagnosing the majority of HIV? Yeah. So I work in New South Wales, and we have a lot of publicly funded sexual health clinics in New South Wales. And when I present this slide there, they often go, oh, the sexual health clinics. Yeah, we're doing a big part of it. However, if you have a look at this, 45% of HIV is diagnosed in general practice. That's massive. To make it clear, just down the bottom, so a GP who's not an ART prescriber, so that's someone who can't prescribe antiretrovirals. And just bear in mind, this data is only from New South Wales. Unfortunately, at this point in time, this data is not collected nationally, so I had to use something. So New South Wales collects it, but it just shows you the impact. And GP ART prescribers, so they can prescribe S100 drugs, which are what these patients are on. But it shows you the impact you're having. Does that come as a surprise to people? I hope so, because, you know, it for most people, they're like, oh, okay, so you do have a huge role to play. This is another really important slide. With testing, who has heard of pre- and post-test counselling? Yeah, and who still uses it or still thinks it should be done or knows their GP uses it or doesn't do testing because they know? So pre- and post-testing was back in the day, and it was lengthy. 5 minutes to go. Cool, thank you. It was lengthy, and basically it is a barrier to testing. HIV testing doesn't differ now. It's just informed consent. So when I go out across the settings and I hear, I just don't have time for that. I just want to slap them, but I don't. And then I have a very diplomatic discussion and talk about this. So it's not there. It's replaced with informed consent. And, you tailor your informed consent. If you've got a patient in front of you that you're expecting a result to come back positive, you'd probably have a bit more of a discussion around that. So this is no different as well. If someone's just divulged they've had a heap of unprotected anal sex with casual partners and they don't know their status, you'd probably have a bit more discussion around it because you're concerned about their result. It doesn't differ. So it shouldn't differ, and just remember you need to always request it. It's not something that just will they'll run the test automatically. It only happens unless you request it. But obviously the patient needs to be aware they're having it. So the role of the primary healthcare nurse, and I guess these slides get me most excited because you've got a huge role to play for various reasons. We've got an existing skill set that patients really warm to. We're non-judgmental, we're active listeners, we're education focused, we're compassionate, we're empathetic, we're trusted. So there's lots of things that we already have in our existing skill set that might make it a lot easier for you than the GP to be able to offer this. Just quickly, some opportunities to think about how you might incorporate testing. They're listed here. I'm just going to move on to some other slides because I don't want to miss them out. But one of the most important things is when the patient asks for the test. I was in a very busy Sydney emergency department having this discussion, and a triage nurse of 20 years said to me, if they ask for a HIV test, we just say no. And I, again, wanted to faint. And I said, okay. And she said, yeah, if it's not part of their presenting problem, it's not our place to do it. If someone's asking for a test, what does that tell you about what they've done their own risk assessment? You don't have to bring it up. Brilliant, because that's half the issue here. People don't want to bring it up because I think it was Mary saying as well, I don't really want to open that can of worms today. They've brought it up for you. Your job's done. So if someone's asking for it, definitely don't say no. And the best question you can say after that, is there any particular reason that you're worried about HIV today? Because they might be really low risk and you can reassure them in that. Or they might actually say, well, I had sex with someone last night. And again, it's a different conversation. So these are part of your slides, but I just wanted to move to some slides that just show some example consultation pathways. And I have to acknowledge Roz here, who put these together along with one of my other colleagues. But these are some pathways because, I understand it is a money model, it's a billing model, it's how do you put it forward as a business case for you guys to do this. So these are just pathways. So the GP offers the test during the consult, they sign the path form, and then the nurse consults with the patient. They discuss a bit more because you've got more time to discuss with your patient, hopefully, and then you collect the samples and send to pathology. So that was one pathway as an option. Another one is the nurse offers the testing. They may consult with the GP signs the path form, and then the nurse will discuss the testing in more detail. They'll collect the samples. And obviously this is going to be really dependent on the GP you're working with and what relationship you have with them. And then the last one is the nurse consults with the patient, discusses HIV and STI testing with the patient, and offers the testing, collects the samples, and then it just sees the GP at the end to sign off on the path form. So there's various pathways, and you can make it work potentially where you work, or put it back to your GP and go this, because as a nurse, this is within your scope of practice. That's the one thing you need to take away from this today. It is well within your scope of practice, but it's how you advocate your own practice to where you're working to go, we're missing all these people. What are we going to do about it? It's within my practice. How can we all incorporate it? Sorry, this is being a bit... There we go. I won't go through I'll just touch on some quickly, but my colleague Michelle Bonner has worked on sexual health competency standards for primary healthcare nurses. One of the things that has come back is how do we advocate for our own practice? How do we increase our scope of practice? We know we can do it, but we need to somehow advocate for it. So these are competency standards for primary healthcare nurses to go, and for yourself, because you can do it, I can tell you now, you can do it, to go, yeah, actually, I can do this. This is what I need to be doing, and I know I can do all these things. So if you do have more questions about these standards, Michelle is actually in the room today, so you can have a chat with her about them, but they're fantastic. One other important thing, which it all comes back to billing. I'm very assertive. I'm just saying 1 minute. Talk to the hand. Is billing. It always comes back to billing, and that's one thing that the nurses are always talking to me about. And an amazing nurse I met at a course I presented at, she's like, it's all about a business case. You've got to go in there with a business case. How can I make money for you? She goes, ultimately I'm here for the patient, but she goes, present it as a business case, and that's how you're going to get runs on the board. So this resource, again, it's a New South Wales STI Programs Unit resource, but it can be used obviously in any state, talks to you about how you can bill these things, because that's the one way you're going to be able to do it, is to show them how you can bill it. And just lastly, some tools that are already in existence that can help you. I'm a specialist clinician, so I can't, I remember these things because this is the only things I deal with on a day-in, day-out basis. Genitals, that's my specialty. But you guys deal with lots of things, and, Roz's presentation really demonstrated that, all the things you need to be thinking about all the time. So there's lots of resources that will direct you on exactly what you need to be doing. So don't worry about having to remember, in a nutshell. And I think I will leave it there. And I really liked a quote of Brian today that leadership is about the power of influence, not control. So this is where I need you guys to be out there influencing what's happening in the world of HIV and STIs, and do my job for me and end it for me. That would be great. Thank you so much.